The '09 ACLS Pharmacology Summary serves as a critical guide for healthcare professionals managing life-threatening cardiovascular emergencies. This module focuses on the specific medications, dosages, and administration routes required to stabilize patients during advanced cardiac life support interventions. Understanding the pharmacology behind these drugs is essential because the timing and accuracy of administration directly impact patient outcomes and survival rates. Throughout this presentation, we will examine the primary agents used in resuscitation, including vasopressors, antiarrhythmics, and rate control medications, ensuring you understand the clinical indications and precise protocols for each drug within the ACLS framework. ACLS Pharmacology Summary 9.1, Vasopressors, focuses on epinephrine and dopamine. Epinephrine is defined as the primary drug for cardiac arrest, acting as a potent vasoconstrictor that improves coronary and cerebral perfusion. It increases heart rate and blood pressure, and the standard dose is 1 mg administered via IV or IO every 3 to 5 minutes. Dopamine is used for bradycardia or post-arrest shock when a patient remains hypotensive. It is administered as an infusion at a rate of 5 to 20 micrograms per kilogram per minute, titrated to the patient's hemodynamic response and blood pressure goals. ACLS Pharmacology Summary 9.2, Antiarrhythmics, covers amiodarone, lidocaine, and magnesium sulfate. Amiodarone is used for ventricular fibrillation and pulseless ventricular tachycardia, with an initial dose of 300 mg followed by 150 mg. It is also used for stable ventricular tachycardia as a 150 mg infusion. Lidocaine serves as an alternative for VF and pulseless VT, and is more commonly used in post-arrest maintenance to prevent recurrence. Magnesium sulfate is the drug of choice for torsades de pointes, where 1 to 2 grams are diluted and administered to stabilize the cardiac membrane and resolve this specific polymorphic arrhythmia. ACLS Pharmacology Summary 9.3, Rate Control Details, Atropine and Adenosine. Atropine increases heart rate for symptomatic bradycardia by blocking the vagus nerve's inhibitory effects on the sinoatrial node. It is given as a 1 mg bolus and can be repeated up to a maximum total dose. Adenosine slows conduction through the AV node to break supraventricular tachycardia, or SVT. It is unique because it must be administered as a rapid push, starting with a 6 mg dose, followed by a 12 mg dose if the rhythm does not convert, followed immediately by a saline flush to ensure it reaches the heart. ACLS Pharmacology Summary 9.4, Reversal and Supportive Agents includes naloxone, sodium bicarbonate, and calcium chloride. Naloxone is a specific reversal agent for opioid overdose, used to restore respiratory drive. Sodium bicarbonate is not for routine use and is indicated only for specific cases, like tricyclic antidepressant overdose, pre-existing metabolic acidosis, or hyperkalemia. Calcium chloride is used for treating hyperkalemia or managing a calcium channel blocker overdose. These medications provide targeted support for metabolic or toxicological emergencies that can lead to cardiac arrest, requiring careful clinical judgment before administration in the field or hospital setting. ACLS Pharmacology Summary 9.5, Routes of Administration, outlines peripheral IV, intraosseous, and endotracheal methods. Peripheral IV is the most common route for drug delivery. You must flush with 20 milliliters of fluid after each drug to ensure it reaches the central circulation. Intraosseous, or IO, involves injection into the bone marrow and is the preferred alternative if IV access cannot be established within 90 seconds. Endotracheal, or ET, is the least preferred route because absorption is unpredictable. When using the ET route, the dosage is usually 2 to 2.5 times the standard IV dose to compensate for poor absorption. Thank you for completing this review of the ACLS Pharmacology Summary. Mastering these medications, their dosages, and their specific indications is a foundational skill for any resuscitation team member. By understanding when to use vasopressors, how to manage arrhythmias with antiarrhythmics, and how to control heart rates effectively, you are better prepared to provide life-saving care. Always remember to prioritize high-quality CPR and early defibrillation alongside these pharmacological interventions. We appreciate your commitment to clinical excellence and your dedication to improving patient outcomes through rigorous adherence to established ACLS protocols and pharmaceutical guidelines.